Constipation. Constipation is a term used to describe an abnormal infrequency or irregularity of defecation, abnormal hardening of stools that makes their passage difficult and sometimes painful, a decrease in stool volume or retention of stool in the rectum for a prolonged period. Any variation from normal habits may be considered a problem. Constipation can be caused by certain medications, example tranquilizers, anticholinergics, antidepressants, antihypertensives, opioids, antacids with aluminium and iron. Second one, rectal or anal disorders, example hemorrhoids, fissures. Third, obstruction, example cancer of the bowel. Fourth, metabolic, neurologic and neuromuscular conditions, example diabetes mellitus, Hirschsprung's disease. Fifth, Parkinson's disease, multiple sclerosis. Fifth one, endocrine disorders, example hypothyroidism, pheochromocytoma. Sixth, lead poisoning and connective tissue disorders, example scleroderma, lupus erythematosus. Seventh, constipation is the major problem for patients taking opioids for chronic pain. Diseases of the colon commonly associated with constipation are irritable bowel syndrome and diverticular disease. Constipation can also occur with a acute disease process in the abdomen, example appendicitis. Other causes include weakness, immobility, debility, fatigue, and an inability to increase intra-abdominal pressure to facilitate the passage of stools, as occurs with emphysema. Many people develop constipation because they do not take the time to defecate or they ignore the urge to defecate. Perceived constipation can also be a problem. This subjective problem occurs when an individual bowel elimination pattern is not consistent with what he or she perceives as normal. Chronic laxative use is attributed to this problem and is major health concern. Pathophysiology. The pathophysiology of constipation is poorly understood, but it is thought to include interference with one or three major functions of the colon. First one, mucosal transport. Example, mucosal secretions facilitate the movement of the colon contents. Second, myoelectric activity, that is mixing of the rectal mass with propulsive actions or the process of defecation. Any of the causative factors previously identified can interfere with any of these three processes. The urge to defecate is stimulated normally by rectal distension, which indicates the series of four actions. First one, stimulation of the inhibitory rectoanal reflex. Second, relaxation of the internal sphincter muscle. Third, relaxation of the external sphincter muscle and muscles in the pelvic region. And fourth, increased intra-abdominal pressure. Interference with any of these processes can lead to constipation. If all organic causes are eliminated, idiopathic constipation is diagnosed. If the urge to defecate is ignored, the rectal mucous membrane and musculature become insensitive to the presence of fecal masses, and consequently a stronger stimulus is required to produce the necessary peristaltic rush for defecation. The initial effect of fecal retention is to produce irritability of the colon, which at this stage frequently goes into spasm, especially after meals, giving rise to colicky mid-abdominal or low abdominal pains. After several years of this process, the colon loses muscular tone and becomes essentially unresponsive to normal stimuli. Atony or decreased muscle tone occurs with aging. This also leads to constipation because the stool is retained for longer periods. Clinical manifestations. Clinical manifestations include abdominal distension, harborismus, that is gurgling or rumbling sound caused by passage of gas through the intestine. Borborygmus, BORBORYGMUS, MUS. Barborigmus. Pain and pressure, decreased appetite, headache, fatigue, indigestion, a sensation of incomplete emptying, straining at stool, and elimination of small volume hard dry stools. Assessment and diagnostic findings. Chronic constipation is usually considered idiopathic, but secondary causes should be excluded. In patients with severe intractable constipation, further diagnostic testing is needed. The diagnosis of constipation is based on results of the patient's history, physical examination, possibly a barium enema or sigmoidoscopy, and stool testing for occult blood. These tests are completed to determine whether the symptom results from spasm or narrowing of the bowel. Anorectal manometry, example, that is pressure studies, may be performed to determine malfunction of the muscle and sphincter. Defecography and bowel transit studies can also assist in the diagnosis. Complications. Complications of constipation include hypertension, fecal impaction, hemorrhoids and fissures, and megacolon. Increased arterial pressure can also occur with defecation. Straining at stool, which results in Valsalva maneuver, that is, forcibly exhaling with the glottis closed, has a striking effect on the arterial blood pressure. During active straining, the flow of venous blood in the chest is temporarily impeded because of increased intrathoracic pressure. This pressure tends to collapse the lung veins in the chest. The atria and the ventricles receives less blood, and consequently less is delivered by the systolic contractions of the left ventricle. The cardiac output is decreased and there is a transient drop in arterial pressure. Almost immediately after this period of hypotension, a rise in arterial pressure occurs. The pressure is elevated momentarily to a point far exceeding the original level, that is, rebound phenomenon. In patients with hypertension, this compensatory reaction may be exaggerated greatly, and the peaks of pressure attained may be dangerously high, sufficient to rupture a major artery in the brain or elsewhere. Fecal impaction occurs when an accumulated mass of dry feces cannot be expelled. The mass may be palpable on digital examination, may produce pressure on the colonic mucosa that results in ulcer formation, and frequently may cause seepage of liquid stools. Hemorrhoids and anal fissures can develop as a result of constipation. Hemorrhoids develop as a result of perianal vascular congestion caused by straining. Anal fissures may result from the passage of the hard stool through the anus, tearing the lining of the anal canal. Megacolon is a dilated and atonic colon caused by fecal mass that obstructs the passage of the colon contents. Symptoms include constipation, liquid fecal incontinence, and abdominal distension. Megacolon can lead to perforation of the bowel. Medical management. Treatment is aimed at the underlying cause of constipation and includes education, bowel habit training, increased fiber and fluid intake, and judicious use of laxatives. Management may also include discontinuing laxative abuse. Routine exercise to strengthen abdominal muscles is encouraged. Biofeedback is a technique that can be used to help the patients learn to relax the sphincter mechanism to expel stool. Daily addition of diet of 6 to 12 teaspoonful of unprocessed bran is recommended, especially for the treatment of constipation in the elderly. If laxative use is necessary, one of the following may be prescribed: bulk forming agents, saline and osmotic agents, lubricants, stimulants, or fecal softeners. The physiologic action of, and patient education information related to these laxatives or enemas and rectal suppositories are generally not recommended for constipation and should be reserved for the treatment of impaction or for preparing the bowel for surgery or diagnostic procedures. If long-term laxative use is necessary, a bulk forming agent may be prescribed in combination with an osmotic laxative. Thank you.